All right, today we're going to be clinical detectives. We're diving into a classic biochemical mystery, phenylketonuria. You probably just call it PKU. We're going to trace all the molecular clues, starting from just one faulty enzyme, and see how it leads to these huge, life-altering effects. And most importantly, we'll see how understanding this stuff can literally save a life. So, our case file opens with a really specific clue. Imagine you're in the clinic and a baby is brought in with urine that has this weird, musty smell. Now, that's not just some random quirk, right? It's a huge signpost, pointing directly to a serious metabolic problem. So what on earth is the connection here?
Well, here's our answer. Phenylketonuria. It's one of the most common inherited screw-ups in how we handle amino acids. And at its heart, it is a surprisingly simple problem. One single enzyme is broken. But that one little failure kicks off this massive, toxic chain reaction in the body.
So, here's our game plan. We're going to follow this trail of evidence from start to finish. We'll look at how things are supposed to work, then pinpoint exactly where the system breaks down in PKU, see the damage it causes, and finally, figure out how we can diagnose and fix it. Let's dive in.
Okay, so before we can understand the crime, we have to check out the normal scene of the crime, right? We need to see how the body is supposed to handle the amino acid phenylalanine. Think of this as our biochemical baseline.
In a healthy person, it's a super simple one-way street. Phenylalanine, which is an essential amino acid you get from eating protein, gets converted into another amino acid, tyrosine. This whole operation happens in the liver, and it's controlled by one critical enzyme that acts like a gatekeeper, phenylalanine hydroxylase.
But, this gatekeeper enzyme doesn't work alone. It's got a crucial sidekick, a cofactor called tetrahydrobiopterin, or just BH4. Think of it as the special key the enzyme needs to open the gate. And because the body is so efficient, there's another enzyme on standby just to recharge BH4 so it can be used over and over. Now remember these sidekicks, they're going to be important later.
So we've seen the normal scene. Now what happens when that gatekeeper, phenylalanine hydroxylase, just isn't working? This is where the story gets serious. The main metabolic highway gets shut down, and all that traffic has to find a new and much more dangerous route.
And this shows the problem perfectly. The normal road to tyrosine is blocked, so phenylalanine starts piling up like a massive traffic jam. The body kind of panics and starts pushing it down these alternate back roads, creating things like phenylpyruvate and phenylacetate. And these are the compounds that cause all the trouble.
Yeah, and this is the critical part. These alternate metabolites are not harmless. They are literally toxic to the brain. They build up, they cross into the brain, and they start messing with crucial things like brain development and the myelin sheath, the insulation around our neurons. Now, it's good to know there's more than one way for this to go wrong. Type I, which is classical PKU, is the most common. That's when the main enzyme itself is broken. But in some rarer, tougher cases, sometimes called malignant PKU, the enzyme is fine, but the problem is with that cofactor, that BH4 key we talked about. So you can really think of it as an enzyme problem versus a cofactor problem. And this is where it all spirals into a metabolic disaster. It's a total domino effect. First, all that extra phenylalanine floods the gateways into the brain, and it physically blocks other important amino acids like tryptophan from getting in. So the brain gets starved of the stuff it needs to make neurotransmitters like serotonin. Then on top of that, because we aren't making tyrosine, we can't make other critical things like dopamine, norepinephrine, or melanin. And here's a super high-yield connection for your exams. The lack of tyrosine directly hits melanin production. And as you know, melanin is the pigment that gives color to our skin, our hair, our eyes. So it's simple. Less tyrosine means less melanin, which leads to hypopigmentation. It's a classic clinical sign you can literally see. So when you add all these biochemical problems up, you get the classic picture of untreated PKU. The neurotoxicity causes severe intellectual disability and seizures. The melanin deficiency gives you the fair skin, light hair, and blue eyes. And that weird musty odor? Well, there it is. Our very first clue, coming back full circle. Let's just focus on that smell for a second, because it's so distinctive. It's caused by the buildup of one of those bad guy metabolites we saw earlier, phenylacetate. When it gets excreted in the urine and sweat, it lets off this super characteristic smell. It's an incredibly powerful diagnostic clue that a sharp clinician can actually smell. Okay, so we've identified our culprit, we've seen the damage, so how do we actually close this case? This is where modern medicine comes in with really sharp diagnostic tools and life-saving treatments.
Diagnosing PKU is pretty straightforward. It all starts with newborn screening programs, which use the Guthrie test. It's a clever test that uses a drop of blood from a baby's heel to spot high phenylalanine levels. If that's positive, we confirm it with a quantitative blood test to get a hard number. Anything over 20 milligrams per deciliter is a red flag. And you might also read about an older urine test using ferric chloride, which turns green if phenylpyruvate is present.
Now, the treatment is a lifelong commitment, but man, is it effective. The absolute foundation is a strict diet that's low in phenylalanine. This means avoiding high-protein foods like meat, dairy, and nuts. And since the body can't make its own tyrosine, it becomes an essential amino acid. You have to give it as a supplement. For those rare cofactor deficient types, you can just supplement with BH4. And of course, you have to monitor their blood levels constantly.
So we've basically cracked the case, but maybe the most important part of this whole story is about prevention. How do we stop the damage before it can even start? And what are the absolute must-know takeaways for you?
The absolute #1 most important key to this entire story is newborn screening. Full stop. By testing every single baby just a couple of days after they're born, we can catch PKU before those high phenylalanine levels have any chance to cause permanent brain damage. It is honestly one of the greatest public health victories of all time.
And here's something really crucial that explains why the diet has to be lifelong, especially for women. It's called maternal PKU syndrome. If a mother with PKU has high phenylalanine levels while she's pregnant, all that phenylalanine crosses the placenta and floods the developing baby. This is toxic to the fetus and can cause major problems like a small brain and heart defects, even if the baby itself doesn't have PKU. All right, let's wrap up the case file. The culprit? A deficiency in the enzyme phenylalanine hydroxylase. The evidence? A buildup of phenylpyruvate and phenylacetate. The classic symptoms? The intellectual disability, the light coloring, and that musty smell. And the solution? A strict low phenylalanine diet plus a tyrosine supplement. Simple, elegant, and life-saving.
Okay, quick pop quiz. Let's see if you've got it. Which enzyme defect is the cause of classical phenylketonuria?
And let's do one more to connect it to the clinic. What's the direct biochemical reason that patients with PKU often have that really fair skin and light hair? Come on, think about that blocked pathway.
And let's just end on this thought. PKU is the perfect example of how biochemistry isn't just about memorizing pathways for an exam. It actually saves lives. Understanding this one little pathway lets us intervene and prevent a lifetime of disability. It's the reason you're studying this stuff, to turn this knowledge into a real, lifelong impact for your patients.